So before starting the management of rectal cancer or any patient, we have to personalize this patient, and we have to consider many things, because these are the factors. Some modifiable and non-modifiable factors are there, and especially the obesity that we is still modifiable, but we cannot easily modify that situation. For some patients with the fear of cancer, they stop smoking. And everybody we know about this, everybody we know everything almost this lecture, but still we can recapitulate something, and some point maybe this matter of debate. So proctoscopic examination and biopsy, should we, all the surgeons, should we routinely do that? Because most of the patients we diagnose by the clinical examination, and when we find on DRE there is a growth, we send this patient for colonoscopic examination, then patient usually come with the biopsy. But when this is negative, then usually we go for the proctoscopic biopsy. But ideally, this is a preferable option. Proctoscopic biopsy should be taken, because sometimes low rectal cancer that may be confused with the anal cancer, where the colonoscopy may not be indicated. And everything, the radiologist so nicely mentioned about the location of the tumor by MRI, but I think this location of the tumor still in the low rectum, and especially up to 8 centimeter, DRE finding is more accurate. And if you combine with the MRI, that is more perfect, the location. And the last question some oncologists asked about the low rectal cancer, should you go for the SCRT or the long course? In my experience, I think probably Orup asked this question because he preferred long course in low rectal cancer, but I agree with the Kaushik, because it depends upon the size of the tumor, where the TRG, we expect the TRG, so that the surgery will be easier if you go for the long course, because in every long course and short course, in every trial, they showed the better TRG in the long course therapy. So in the mid rectal, upper rectal, the much more TRG is not required, but in the low rectal, TRG is required, especially for the bulk of the tumor, but not for the sphincter saving issue. And he's rightly mentioned, because with the long course and short course, whenever we go for the, did you expect we can save the sphincter? No, because this is accidental. All the thing, like what is the main problem with the declaration of the CCR is very difficult for the radiologist, for the oncologist, and for the surgeon. So we have to personalize, to declare the CCR, and to go for the WW policy. But especially, special problem is that the CCR, there are a lot of gray area. Whether we should take the biopsy from the superficial fibrotic area? No, the answer is no, because that will not prove all the thing, because there are lymph node and the intramural lesions, so that biopsy should not be taken. So when we declare the CCR, especially we should consider absolutely when the patient is very morbid patient, where the surgery is not at all possible. In that case, we should go for the declaration of the CCR, and we can advise with educate counseling about the regrowth of the cancer, about WW policy. In our institute and in my private practice, only 4 patients in the last 5 years, we are following this patient with the organ preservation, I mean the WW policy. So location of the tumor is very important, and everybody will agree that MDT is a must for every rectal cancer. In fact, every cancer patient requires MDT. And this decision making, we go upfront surgery in the T1 and the and the upper rectal cancer, especially the rectosigmoid growth. So there are many confusing issues in some center like the Cleveland Clinic. They prefer the tumor above the peritoneal reflection, they treat as a colon cancer, so they can go for the upper. But we found many problem with if we think about the peritoneal reflection, because it varies. The patient having the ODS, this peritoneal reflection is below. That actually does not correlate all the time with the middle valve. So, but if we consider the NCCN, the definition of the rectum, the sacral promontory to the upper border of the pubic symphysis, I think that is very good marking. Below that, if we consider the rectum, so I think that is very good thing to consider the total rectal cancer. So, but rectosigmoid lesion, we usually in our institute we go for the upfront surgery, and T1, and in some cases even in T2, where the major surgery is very difficult for this patient with his multiple comorbidity. And in mid-rectal cancer, T3AB, we can go for the, if we follow the ESMO guideline, we can go for the upfront surgery. So when we go for the restaging, so thing is that, well, if we decide this patient will go for TNT, actually in our institute we don't adopt this TNT routinely, but we personalize the patient. Go for the standard CRT or SCRT, and we restage this patient. If we find this patient is still the MRF is threatened, we go for the TNT. Or still, when we think this patient is not, R0 is not possible, then we go for the TNT. Because sometimes still we are in the dilemma that probably TNT may be in some, for some patient may be over treatment. Everybody we know when we re-MDT, but this patient after restaging, this patient, all patients should go for the re-MDT. And if we go for the local excision, positive margin, and sometimes this patient, sometimes very difficult to decide the T1 and T2. That is usually by the endoanal ultrasound and MRI in combination and with the digital impression, digital RDRD impression. In that case, we decide this is T1 and we'll go for the local excision. But sometimes with histopathology it comes with T2, then this patient needs re-MDT, whether this patient will go for the TME or radiotherapy. Still today, all the patients prefer radiotherapy than the TME surgery. Another unusual situation like the carcinoma peritoneal, liver mets, and unusual site metastasis, re-MDT is required. That is nicely described by my previous speaker, the best neoadjuvant therapy. Actually, there is no best neoadjuvant therapy. Every center, their rapid trial, now, the last day they are saying the local failure is more in rapid trial. I think rapid trial is a very good trial. We prefer rapid trial, but thing is that the T4A, T4B, N2, EMVI positive, all are high risk tumor, they are dealing with the rapid trial. So we expect the higher local failure in the rapid trial. So if you compare with the T3 with the rapid trial, that is not the, that will not be valid or rational. But rapid trial is, I think that's a good trial, but still they are showing that local regional failure is high. But in our practice, in our institute, we usually go for the standard protocol, but honestly speaking, in low rectal cancer, I do agree with Dr. Orup, we still go for the long course therapy, standard time modal therapy, but after surgery, all patients initially decided this is locally advanced tumor, but what is initially decided for the CRT, surgery and adjuvant therapy, in some patients still with re-MDT, we decide whether this patient at all should get this adjuvant chemo or not. Some patients are still with follow-up protocol after surgery. All approach are good, but emphasis should be given on the oncological clearance. But in our institute, in my personal experience, we prefer minimal invasive surgery. We go for the laparoscopic surgery in all patients, unless is there any contraindication. But that is, and this is the recommendation of the NCCN and the American Society of Colon and Rectal Surgeons. That is already discussed. What about the lateral lymph node dissection? Should we start with lateral lymph node dissection like the Japanese people? There is still in confusion. The Western people still did not adapt because the patients are bulky, complication is more, neurological problem is more. But the Eastern people probably they are comparatively thin and the lateral dissection is easier. And I personally did in 2 patients. The surgery is not that difficult, but still we are thinking should we adapt this thing for the all patient after getting new adjuvant, and with the MRI is there any lateral lymph node and the size. So if we are still thinking, but only 2 patients we did. And this is absolutely for the surgeons, some technical issues, and whether the high ligation, low ligation. So there is no oncological benefit between the high ligation and low ligation. But thing is that if you get the length, if you tension-free anastomosis, either way you can go. Whether you go for the splenic flexure mobilization or not. Low rectal cancer, almost all patients need complete mobilization of the splenic flexure. But sometimes in Asian people, in many literature, you will find 70 to 80% patient needs the splenic flexure mobilization. Their assessment is with the diet, the Asians, the colon, especially the sigmoid colon, is more redundant than the other people. So, but in my opinion, if you go for the low rectal anastomosis, so it's better to go for the splenic flexure mobilization. Otherwise, there will be tension. So the issues are sometimes it happens even sometimes the percentage is not bad about the ovarian involvement, the Krukenberg's tumor, the local spread from the rectal cancer. So routine prophylactic oophorectomy should be done. The grossly normal ovaries need not be removed. Ovarian metastasis from rectal cancer occur up to 6% of patients and are usually associated with widespread disease and poor prognosis. Oophorectomy should be considered if the organ is grossly abnormal in postmenopausal females. Bilateral oophorectomy is indicated if one ovary is involved because there is a high risk of occult metastasis in the contralateral ovary. So that I discussed about the decision making after restaging. If no response with CRT, then what? TNT or surgery? If no response with TNT, should we consider surgery? So that I asked Dr. Kaushik, probably what will go, probably chemotherapy will be continued, but this patient actually does not improve. About the molecular profiling, probably there are lectures on these issues. They will discuss elaborately. But in our institute, every CRC patient we go for the at least MSI, and in metastatic cancer, then we go for the RAS profiling and BRAF commonly. These are the quality of TME. One of our students is started thesis about the quality of the TME with the histopathological, I mean the macroscopic assessment of the major rectal excision with the histopathological assessment. She just started her thesis. It's a good thing because complete TME is required for the to prevent the local recurrence. Grade of anastomosis. And for the surgeon, this is very, very important quadruple assessment. ICG facility is not available everywhere, but at least every patient should go for the leak test. Every patient. And donut examination of the anastomosis. So you can go for the grading of the anastomosis. But leak test is very, very important. Question of diversion. In all patients, in all cases, should you go for the ileostomy? Answer is no. So when we prefer ileostomy? In rectal cancer, most of the patients nowadays are getting the neoadjuvant therapy. So any anastomosis below the peritoneal reflection, we usually go for the covering ileostomy. And patient getting neoadjuvant therapy, we do not take risks about the anastomosis, especially in the low-lying anastomosis. So in our institute, we prefer ileostomy. One question was asked about the closure of the ileostomy before starting neoadjuvant. But I little differ with that answer because I think once the adjuvant therapy is indicated, patient should complete adjuvant therapy because ileostomy is not without any complication reversal. If we reverse the ileostomy before starting your adjuvant therapy, but you don't know when this patient will back to you with his total closure after closure, because you know you may get this patient with the treatment delay. You can go for the complication of the ileostomy, and this patient will go to you after 5 to 6 months. But ideally, this patient should start adjuvant therapy within 2 months. So I think the patient is indicated for adjuvant therapy, should start adjuvant therapy within 2 months, and after that patient can go for the ileostomy closure. If ileostomy closed within 2 months, no problem. Even after 6 months, no problem. There is no surgical technical difficulties. But thing is that one thesis is done by one of our students, the early closure of the ileostomy, and if we go for the closure of the ileostomy in the same admission, that is a different issue. This patient after closure, patient can go to the medical oncologist for the adjuvant therapy. But I think that is not done. Probably the adjuvant therapy should be done first. So any anastomosis technique is good. Everybody will know when we go for the APR. We have to consider some situation. If the patient is blind, patient is crippled, patient needs APR, this patient we consider a blind patient is very difficult to manage his stoma, and the crippled patient, severe arthritic patient cannot manage his stoma. So in this particular patient, we can think about whether should you go for the TNT and all this treatment to get the CCR, and can we declare the WW policy for this special kind of patient. So adjuvant RT. So I think this adjuvant RT we practice in very limited situation in rectal cancer. All patients where the radiotherapy is indicated, all patients should get neoadjuvant radiotherapy. All patients, but in very limited situation, adjuvant RT is there. If they are upstage in histopathology and the tumor perforation accidentally and the CRM involved or threatened after, when the decided MRI shows the threatened MRI, a normal CRM is free, but when you go for the surgery and final histopathology come with the CRM positive, probably in that case adjuvant therapy is indicated if it is not given previously, or any reason patient did not take adjuvant, neoadjuvant radiotherapy, but now patient is convinced, though the complication, toxicity, all are more in the adjuvant setting of radiotherapy. This is some slide from in my personal practice. About the SCRT, this is my personal series actually. There is 41 patient. I did SCRT and 29 patient with early surgery, I mean the second week surgery, and 41 patient I did the delayed surgery. What difference I find? First thing, dissection plane I didn't find any difference. Even the early surgery, I find some edema that helps in my dissection, and delayed surgery, I mean the after 1 month and 6 weeks, I didn't find any difficulty. Surgical site infection, no. But all patients, of course all patients went for the laparoscopic surgery. And the CCR, nil. TRG, no TRG in early surgery. TRG 1 and 2 in delayed surgery, where TRG 0 is CCR. In that TRG, CCR 1 and 2. Bone marrow suppression in one patient in early surgery, only some sort of pancytopenia developed, and otherwise all patients there is no bone marrow depression in the delayed surgery. But still, I myself prefer nowadays all patients, because the Stockholm 3 by this time they proved the delayed SCRT and delayed surgery is better than early surgery. But some patient, young patient, they psychologically, they think the early surgery, they want early surgery. I find somebody can still prefer early surgery if there is no comorbidity immediate after the early surgery. But I do agree with my previous speaker in short course radiotherapy, so no excessive toxicity. And about the CRM positivity, you know, if you go for the different literature, you'll find the percentage, different type of percentage, but it depends not only the skill of the surgeon, the disease, preoperative radiotherapy, preoperative radiological finding, all these issues are there, and the location of the tumor. In my cases, I got 29 patients, the CRM positive, but and nowadays I'm rarely getting the CRM positive. This is the very good information from my side. For in the last 2 years, if you consider all patients got neoadjuvant chemoradiation, the CRM positivity is less. Probably there is Professor Zahid sir is there, probably he will agree with me. With the NSCRT, CRM positive is very, very low. So every patient, where indicated, all patients should go for neoadjuvant, because local recurrence is a real burden for the patient, difficult management for the surgeon, local burden for the nation as well. So where possible, where indicated, every patient should go for the NSCRT. That I mentioned about the upfront surgery, and diversion I mentioned. Another issue is pre-reversal, what we do actually. Should we do for every patient colonoscopy? Yes, in some patient should go for the full colonoscopic evaluation if it was not done previously, and ideally, should we go for the lipogram or colonoscopy? So both is applicable. Even sometimes one is complementary to other. Sometimes we find with lipogram the distal sigmoid colon, left colon is narrow, but very difficult to decide whether this narrow is okay or not okay. So at the same time, if you go for the colonoscopy and easily pass, so that you will be comfortable before closing your ileostomy, so you have to again personalize that issue. So about I do agree about the WW policy in some situation where the surgery is really difficult for the patient, because if you go for the WW policy, patient should be well counseled about the local regrowth. You know, local regrowth, you can go for the salvage surgery, but not all patient. Around 90% patient you can go for the salvage surgery. So, careful patient selection and individualizing of treatment approach is the key for the optimal outcome. Thanks for patient sharing.